Hello again, everybody. This will be a talk on the approach to breast masses and breast cancer. Now, we are not in this talk going to go over the symptomatology of breast masses and breast cancer. We're not going to go over risk factors or epidemiology. That will be the subject of another talk. This is going to be a very focused algorithmic talk that's fairly high yield for step 2 and 3. And I'm going to direct you to the particularly high yield stuff. But any of this stuff could come up on the exam, but I will point out to you what's particularly important as we go on. Now, I know that some of you who watch my videos regularly are not healthcare professionals, and I want to put out this disclaimer here. Breast cancer is an extremely delicate topic. I know that there are people that are going to watch this video or come across it who are either breast cancer patients themselves or loved ones. And personally, my mom went through breast cancer. I know how dauntingly scary it is. It's traumatizing. And you go out there and you read online all this information, and this is by no means a substitute for what your surgeon tells you or what your oncologist tells you. There are varying ways to go about this. What I'm talking about here is how you approach this on licensing examinations. So it may differ from what your doctors tell you, and I don't want to undercut them. You should always go with what your doctor tells you because that is indeed what's best for you. So I just want to put that disclaimer out there. Okay. If you haven't had the opportunity yet, please consider subscribing to my Patreon. I have the link below in the description of the video, or you can click on the I button in the upper right-hand corner. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. I very much appreciate your consideration. All right, so we're going to talk about how we approach the breast mass, and then we'll talk about how we approach breast cancer. Not all breast masses are cancer by any means. So we'll talk about both. We'll also talk a little bit about some terminology that you may hear come up. That's pretty important clinically when you're dealing with a breast cancer. And then we'll go into the treatment. And treatment for cancer is always very complex, and there are different ways to go about it, and we personalize it. And so it doesn't really come up on the exam. But for breast cancer, there are some generalizations that you do need to be familiar with, and so we'll talk about that. All right, so how do we approach the breast mass? You got a woman comes in, or a man, I suppose, who comes in saying they felt something in their breast. Now, they may have felt it during a shower, or they just may have stumbled across it incidentally. At that point, you want to know what the patient's age is. If they're under 30 years of age, we tend to go for an ultrasound. Why? Because they have denser breasts. Mammography is not great for people with very dense breasts. If they're over 30, then you can go for mammography. Now, if the patient is premenopausal, and this goes for whether they're over 30 or under 30, but I put it over here. If they are premenopausal, you want to evaluate them at day 3 to 10 of their cycle. It's just a better time to evaluate it because certain breast masses can get bigger with the cycle, and so you want to evaluate them at day 3 to 10 of their cycle. That could come up. Okay, so let's say they're under 30 years, you get an ultrasound, and you see the mass. If it is a simple cyst, at that point you know it's not cancerous. And so you don't need to do anything, you can leave it alone, or if the woman really is uncomfortable with it, she doesn't want it there, you can do a needle aspiration and get rid of the cyst that way. If it is a complex cyst or a solid mass, then you need to do a biopsy. You do an image-guided stereotactic core biopsy, and at that point you'll be able to determine whether it's benign or malignant. If the patient's over 30, then you can do mammography, but you could do an ultrasound or you could do both. Really just depends on the density of the patient's breasts. Now, you can also come across this by screening mammogram. Women of a certain age are supposed to get screening mammography every year. And so if you come across features suspicious for malignancy on screening mammogram, you're going to do the same thing. Now, you get a mammogram. What does it mean to have features suspicious for malignancy? There are a variety of features when you see a mass that make you think malignancy. And you've got radiologists who go to fellowships for just breast imaging, so it's very complex. But one thing I want you to know when you're reading a radiologist report, I want you to know for exam purposes, for clinical purposes, is something called architectural distortion. Architectural distortion is highly suggestive of malignancy. So if you have features suspicious for malignancy, you're going to go ahead and get biopsy, the same way as if you had a complex cyst on ultrasound. So when you get a biopsy, you'll know if it's benign or malignant. If you're dealing with malignancy, it can be invasive, if the tumor cells have spread into surrounding tissue, or if it's carcinoma in situ, in which case the cells are contained within the ducts or within the lobules. And invasive or carcinoma in situ can be either ductal or they can be lobular, ductal being more common. Now, when you have a biopsy that comes back for invasive breast cancer, it's going to tell you a variety of different things. And these are all relatively important things for you to know clinically, but for exam purposes, what you want to be familiar with are these three things. At a molecular level, the estrogen receptor, the progesterone receptor, and the HER2 or HER2-neu oncogene. Those three things are going to play a big role in treatment as well as prognosis. So they're basically what the name says. Estrogen, progesterone receptor, collectively known as hormone receptor, and the HER2 oncogene. There's another thing called Ki67, very low yield for your exam, but what it is a proliferation marker protein that sort of tells you to what degree the cells are proliferating and how fast. So low yield for your exam. Histologically, you'll get a picture of whether or not it's detected to be invading, surrounding lymphatic or vascular structures. And then you have these three things: mitotic rate, nuclear pleomorphism, and tubular organization. And these things figure into the grade. Now, when we stage breast cancer, we use the TNM system: the size of the tumor, the degree to which it's invaded nodes, and whether or not there's metastasis, distant metastasis. We do not stage it based on the grade, but we do like to know the grade because it gives you an idea of how aggressive the cancer is. And that does play a little bit of a role in prognosis. So we use three things: the mitotic rate, and that's just based on the number of mitotic figures that you see on your high-powered field; the nuclear pleomorphism, how different the nuclei look from one another; and then the tubular organization. Does this tumor form organized tubules? And you rate this from 1 to 3, each of these from 1 to 3. So 3 being the higher grade, more concerning, more aggressive. And so if you see more mitotic figures, that's a 3, less is 1. If you see more pleomorphism, that's a 3, less is 1. And if you see fewer organization of tubules, that's a 3, more organization is 1. And you combine those scores and you get what's called a Nottingham score, and you can grade it 1, 2, and 3 depending on the sum of your scores. Okay, you don't need to know that for your exam, but clinically you'll see that come up when you get a biopsy and it comes back for positive for cancer. That will be given to you automatically, so it's useful to know. The two most important things histologically are the lymphovascular invasion, because that is associated with spread to lymph nodes, and the mitotic rate, because that really tells you how fast the tumor is growing. Okay, now there's some terminology that's based on molecular findings. This is also low yield for your exam, but it's very important clinically for really getting a prognosis of what, how aggressive the patient's tumor is. So the most common is what's called luminal A, and that's where you have a hormone receptor that's positive and the HER2 is negative. And this is the most common, and it has the best prognosis. Luminal B is where you have a hormone receptor that's positive and the HER2 is positive. Now, in the past, this was a pretty bad prognosis, but now we've got targeted HER2 chemotherapy drugs. And the prognosis for this is actually almost the same as for the luminal A. The only problem is it tends to be a little bit more aggressive prior to treatment. But the prognosis is a lot better with these HER2 cancers. Then there's the HER2 enriched. That's where you have negative hormone receptors and HER2 positive. That's slightly worse prognosis than the luminal B. And then there's the very much feared triple negative or basal-like, and that's where all three are negative. This is the hardest to treat because we don't have any targeted drugs. We don't have any hormone blockers or HER2 blockers. Those are going to be ineffective against these cancers. So this tends to have the worst prognosis. It's also strongly associated with the BRCA mutation. So you may see this more in younger patients because they're predisposed if they have that BRCA mutation. All right, so how do we approach treating invasive breast cancer? So if you've got a tumor that's T1 or T2, and that is that's less than 2 centimeters is T1, 2 to 5 centimeters is T2, and it's a single lesion, then you can go ahead with lumpectomy. And a lumpectomy is just where you remove the tumor as well as remove a surgical margin. And at that point, you can be done depending on the molecular status. You're also, with any surgery with breast cancer, you're going to get a sentinel node biopsy. And a sentinel node biopsy is where you check for the surrounding lymph nodes to see if there's any spread. Now, in the past, we used to just remove all the lymph nodes. Unfortunately, when we did that, you've got patients with severe lymphedema because you've removed so many lymph nodes. And remember that lymphatics are in series and parallel, and if you remove a bunch of lymph nodes, you're going to increase the backflow pressure, and so you can get lymphedema from that. So we want to avoid that. So what we do instead is we inject a dye, or we inject technetium, or you can do both, and you look for the first nodes that dye goes to, with the theory that if the tumor were to spread, it would be those nodes that the tumor would spread to first. You take those nodes out, you look at it under a microscope. If those nodes are negative, then you don't need to go any further. You don't need to dissect the axillary lymph nodes. Now, when you do the lumpectomy and you get clear margins, at that point, then you're moving on to medical therapy. If they are HER2 negative, you just do radiation, and then if they're estrogen receptor positive, you'll continue with 5 to 10 years of either a selective estrogen receptor modulator, namely tamoxifen, or an aromatase inhibitor like letrozole. And usually you go with tamoxifen if they are premenopausal, and you'll go with the aromatase inhibitor if they're postmenopausal. Now, if you do a lumpectomy and you're unable to clear the margins, usually if you're dealing with a bigger tumor, then you need to proceed to mastectomy. So I should have probably drawn, I don't know if I can, there we go. I should have drawn an arrow like that. So that's what you would do if you're unable to get clear margins. Oh, my laser pointer back. Okay, now, if you've got a patient with a smaller tumor, T1 or T2, single lesion, they can elect to do a mastectomy, where you remove the entire breast. That's up to them. It's their choice. You don't have to, but it's an option. So if you get a mastectomy, you still need to do a sentinel node biopsy. You're going to get clear margins with that because you're removing the entire breast. If you do that, then radiation is not needed. You don't need to do radiation, but you will do chemotherapy if they're HER2 positive, and that's chemotherapy with traditional chemo agents like docetaxel and the targeted HER2 drugs like trastuzumab, and there are other ones that are out there now. And then you would also do the prolonged 10-year therapy with the tamoxifen or the aromatase inhibitor. So you still proceed with this. The only difference is if you do a mastectomy, you don't need to do breast radiation. You will also, in any case, you're going to do radiation and chemotherapy if you have positive lymph nodes. You're going to have to do radiation and chemotherapy. And that radiation will not only go to the breast, but you'll also need to do axillary radiation as well. Now, when do we have to get a mastectomy? You have to get a mastectomy if you've got multicentric disease, so more than one tumor in the same breast, or if you just got a poor tumor size to breast size ratio. So if you've got a patient with a small breast and they've got a big tumor, it really doesn't make much sense to do a lumpectomy because you're removing the entire you're removing that entire tumor and most of the breast anyway, and it's going to be hard to get good margins if you try to do that. So you just do a mastectomy at that point. So women with smaller breasts tend to go more towards mastectomy, but it really just depends on your judgment with the size to the tumor size to breast size ratio. Okay, now if you've got locally advanced breast cancer, namely a really big tumor, then it makes sense to do neoadjuvant chemotherapy. And neoadjuvant chemotherapy just means chemotherapy before surgery. And you'll do it afterwards too, but you'll do it before surgery. And the idea is to shrink that tumor down to make it easier to get the tumor out. And that can be followed either by mastectomy or lumpectomy. So that's neoadjuvant chemotherapy. The chemotherapy that you use just depends on whether it's HER2 negative or HER2 positive. If it's HER2 positive, you're going to use one of those HER2 drugs. If it's HER2 negative or HER2 positive, you can also use traditional chemotherapeutic agents as well. So that's our approach to invasive breast cancer. Now, I just want to follow up with a little bit of information on, we kind of went into this on treatment. What I want you to know, which is high yield for your exams, is when you're dealing with luminal-like cancers, so you've got hormone receptor positive, then you're always going to follow that with endocrine therapy. Remember the tamoxifen or the aromatase inhibitors. If it's luminal A or and it's not spread to any nodes or spread to very few nodes, you can just do endocrine therapy. If it's luminal B, namely if you're dealing with like a triple positive, it's hormone receptor positive and it's HER2 positive, and no matter what, if it's spread to several lymph nodes, then you're going to do chemotherapy as well. You'll do chemotherapy as well, and then followed by endocrine therapy. And in both of these, if you do a lumpectomy, remember, you're going to get radiation. If you do a mastectomy, you don't need to do radiation. For the triple negative tumors, you should get BRCA testing, particularly if they have a family history, but no matter what, because triple negative is associated with BRCA, you should get BRCA testing, because then in that case, if you've got a patient that's BRCA positive, you're going to remove the other breast, and then you'll want other family members to know that there's BRCA in the family so they can know, because these patients, people who are BRCA positive, even if they don't have breast cancer, they've got such a strong risk that a lot of them will just want to go ahead and get a double mastectomy to eliminate their risk or greatly reduce their risk of breast cancer. And then again, HER2 positive, even if it's hormone receptor negative, you're going to be giving them chemo and the HER2 HER2 therapy. Trastuzumab is also known as Herceptin, in case you don't know that, and pertuzumab is a similar agent that can be given in addition to trastuzumab. This is called Perjeta. So you do chemotherapy with the HER2 agents for tumors that are HER2 positive. There are other chemotherapy drugs that you can give, like docetaxel and anthracyclines. You don't need to be familiar with those for your exams, but just know that they exist as part of chemotherapy. And that's all I've got for you. This is everything you need to know for breast cancer as far as diagnosing it and treating it. But I'm going to give another talk where I talk about more particulars about the difference between carcinoma in situ and invasive cancer, the histology of it, risk factors, and stuff like that. That's also high yield for your exam, so stay tuned for that.